So I will give you a very personal overview on the challenges related to primary sclerosing cholangitis this year, and also, I'm afraid, in the next years to come. So these are my conflicts of interest. You all know that primary sclerosing cholangitis is a chronic and inflammatory sclerosing disease of the large intra and or extrahepatic bile ducts, which presents around the age of 30 to 40 years in most cases, but can even present in young children. And it is different from other autoimmune liver diseases because slightly more males than females are affected by this disease. The prognosis, as you know, is quite bad, depending on the population you look at. On a population-based level, it's around 21, 22 years until death or liver transplantation. But if you look in the transplant centers, it will be much less, and even less than 15 years until these endpoints will be reached. So the challenges that we are still facing clearly are that we don't have an effective therapy, not an effective drug therapy, and not an effective, I'm afraid, endoscopic treatment. And this clearly relates to the lack of understanding of disease pathogenesis. And I will spend some time on disease pathogenesis and some of the data we have generated recently. There is a greatly increased risk to develop hepatobiliary malignancy, and we still lack means for early diagnosis of the disease itself and also of the complications, namely development of cholangiocarcinoma, for which it is so crucial to diagnose it in the early stages. You all know that this disease has a very peculiar association with an inflammatory bowel disease, which is clearly different from the classical inflammatory bowel disease, ulcerative colitis or Crohn's, because it is usually a pancolitis, which is predominantly located on the right side of the colon, often with a so-called backwash ileitis, a phenomenon we don't really understand immunological wise, and frequently also with rectal sparing. And we also know from the genetics and also now from the microbiota associations that this large bowel inflammation is clearly separate from classical IBD. And that is why we should, I think, call it Psc-associated colitis in most of our cases. However, having said that, we don't really understand what that means for the liver disease and the bile duct disease itself. We know that the presence of IBD and the type predominantly present influences the course of disease from this large and very nice retrospective study from the International PSC study group. Here you can see that the patients presenting with a Crohn's type of colitis have a significantly better outcome than all the other patients, including patients with an ulcerative colitis type of disease and including patients who don't have overt colitis at all. So that could mean that either all PSC patients have some degree of colitis, but some remain subclinical or cannot be detected, or that Crohn's type confers some type of beneficial effect on disease course. And I will come back to that a bit later. So for me personally, the first biggest challenge in this disease is that we don't have a clue to disease pathogenesis. And I was looking up the clinical trials webpage to look for the ongoing clinical trials in PSC. And there are many of them, almost 100, but none of them relates to a PSC-specific pathogenetic mechanism. So statins, sulfasalazine, etc. are all old drugs that are being repurposed to try to treat this devastating disease. So Tom Carlson has proposed this pathogenetic wheel, and I will shortly guide you through this. We have started to understand the genetic risk factors, which clearly suggest that this disease is an immune-mediated, maybe autoimmune disease. However, genetic risk accounts for only around 10% of disease risk. So the environmental factors are much more important than the genetics. We have some clues regarding the connection of the gut and the liver immunology-wise. However, this has so far not related in any effective treatment for PSC. We do have ideas about bile acid toxicity and may be disturbed by carbonate umbrella in the bile ducts. However, also that has not related to any effective treatment options. And actually in early stage disease, it is far from clear how much bile acid toxicity contributes to the disease. We know that it is an immune-mediated, maybe autoimmune disease, and we have some clues as to dysfunctional T-cell regulation. I will come back to that. And we have clearly a disease predominated by peribiliary fibrosis. However, the mechanisms, maybe disease-specific mechanisms of peribiliary fibrosis are incompletely understood. So one topic that could unite the fact that PSC is so greatly associated to inflammation in the bowel and the immune system, it could be the microbiota. So I will spend a few minutes on our knowledge of the contribution of intestinal and also biliary microbiota to this disease. Clearly, we can state, and several studies have shown that the microbiota composition is different in PSC from healthy donors, but it is also clearly different from patients with ulcerative colitis and the other autoimmune liver diseases. You can even use these microbiota fecal profiles for diagnostic purposes with a very high accuracy and an AUC of almost 90%, differentiating PSC from healthy donors. In this study, even specific bacterial taxa were associated to markers of PSC disease activity, namely serum alkaline phosphatase levels. And the one taxon that was clearly positively associated with increased ALP levels was Enterococcus, which is interesting because Enterococci have recently also been implicated in the pathogenesis of alcoholic hepatitis, but the group of Bernd Schnabel. Now, these bacteria not only interact directly with the immune system, they also produce metabolites. And we investigated in a cross-regional analysis together with the Norwegian colleagues whether we see similar increases and decreases in abundance in different bacterial taxa. And just to mention one, the gamma proteobacteria, as an example, E. coli is one of those, are bacteria that produce metabolites that can travel via the portal tract to the liver and activate the immune system within the liver. And one such candidate is cysteamine. And the group of David Adams in Birmingham has shown that cysteamine, which is produced by the bacteria, is the substrate of vascular adhesion protein 1, VAP1, which upon activation induces the expression of MAdCAM1, which is important for the adhesion of leukocytes on the sinusoidal endothelium in the liver, and thus maybe linking bacterial composition to increases in liver inflammation, also in PSC. Now, what we know so far from the microbiome is based on 16S sequencing data. with which it is very difficult to delineate sequences to specific bacterial species. So we went on to perform fecal metagenomics, and this project has not been published yet. Together a project which is led by the Kiel group and the Oslo group, to which we have contributed. And you can see, just as an overview, that on the lower right-hand side, the correlation networks between the specific bacterial species in certain areas, Clostridiales, for example, is much less pronounced than in healthy controls. And we will report some increases and decreases in metabolites, mainly vitamin metabolites, interestingly, that could be further analyzed for the pathogenesis of this disease. What is even more important than studying fecal microbiota is the mucosa adherent microbiota, and there are very few studies reporting differences between Psc and controls. And I think this has become even more important since the publication in Nature Microbiology by Nakamoto and colleagues, who could, in very nice and elegant studies, demonstrate that the feces of Psc patients frequently contain bacterial species which are able to induce pore formation in the gut. They then can translocate in mice to the mesenteric lymph nodes, activate immune cells, T cells, to become Th17 cells, which are then promoting liver inflammation in models of experimental cholangitis. So this was the first study to demonstrate a mechanistic link between fecal bacteria and periductal inflammation. And I think there is more to come the more we learn about the mucosa adherent microbiome in Psc. Now, we have already shown a few years ago that you can take bacteria isolated from the bile ducts of Psc patients to stimulate T cells from the same patients. And these bacteria in Psc patients induce increased expression of the pro-inflammatory cytokine IL-17, as you can see here, with using enterococci or staphylococci, and actually most pronounced by using Candida albicans. And we could recently show that this can not only be shown in vitro after several days of culture, but also directly ex vivo in patients. So Psc patients have increased frequencies of Th17 cells upon ex vivo PMA ionomycin stimulation. And this suggests that the differentiation and activation of these cells is induced already in vivo, again linking potential microbiome changes to the dysregulated immune response we can observe. Now, but Psc is a disease of bile ducts and not of any other organs besides the colon. So what is actually going on in the bile ducts? We showed several years ago that in Psc patients, sometimes we see bacterial translocation in the liver into the portal tracts. So this suggests that bacteria in the bile ducts themselves may be relevant for disease pathogenesis. So we went on to plan a prospective study where we compared Psc patients with control ERCP patients and analyzed their biliary and upper GI tract microbiome. And you can appreciate that in Psc, the diversity is reduced, and we could show that indeed the bile fluid harbors a different microbiota compared, for example, to the duodenal fluid here shown in yellow, and the oral cavity, and also the duodenal mucosa. And actually, the bile fluid was the only compartment which showed significant differences between controls and Psc. And we could then link again the Enterococcus abundance with the concentration of the potentially cytotoxic and malignancy-inducing taurolithocholic acid a bile acid that is known to induce bile duct damage in mouse models. So the clinical question arising from that is, can microbiota be targeted for the treatment of PSC? And the crudest method to do that clearly is fecal microbiota transfer or transplantation. And last year there was a pilot study published with, I think, around 10 patients included, which demonstrated first the feasibility of this approach. It didn't show any great response regarding ALP reductions, but it did show that some of the donor taxa correlated with ALP responses. So I'm not sure whether this will be followed up in larger studies, but it's a proof of concept that microbiota changes can be induced also in PSC patients using this crude method. And another method that has or was very popular, especially in the pediatric community, is the treatment with oral vancomycin. And there have been a few reports about very successful treatment of PSC using vancomycin, even cure of PSC. And there's now a study in press coming from the States using a very elegant propensity matched comparison. And it very clearly shows that oral vancomycin and also urso, unfortunately, was not effective in children with PSC in preventing the listing for transplantation or regarding the lowering of gamma GT values after 1 year of treatment. So coming to the cells that may be involved in PSC pathogenesis, we know for a long time that PSC has a very strong association with the HLA loci. It's similarly strong to celiac disease, where we know that a single antigen is causing disease. So we assume that the adaptive immune system plays an important role here. So we ask the question, what about T cells in PSC? And we first performed, and this is also unpublished work I'm sharing with you, we first performed a multicolor FACS, so flow cytometry investigation in PSC patients and control patients using over 70 surface markers. And to make a long story short, the biggest differences we observed in peripheral blood were differences in the T cells, mainly a very different, as you can see on the lower right-hand side, CD4 to CD8 ratio in the cholestatic liver diseases PSC and PBC. So we went on to, in more detail, analyze the T cell profile of our patients. And for this, we used a new method, and I'm showing you that because I think that the new technologies can very nicely be used to get a deeper insight into disease pathogenesis, if we are able to obtain enough material from the inflamed organ, the liver itself. So we use the technique of site sequencing. This is a single cell RNA sequencing method that is combined with the staining of the cells using antibodies. And these antibodies are bar-coded with an oligo so that in the end, the sequences can be delineated to a specific phenotypic cell. So what we did was we took 9 cirrhotic livers and 2 non-cirrhotic livers from PSC patients. These were explant livers, and these were resection margins from cholangiocarcinoma resections. And we performed the site-seq analysis to generate a T-cell atlas from the liver of PSC patients. And this worked very nicely. And I want to focus on a very surprising finding. We detected a population of CD4 positive T cells with a naive-like phenotype. And that was surprising to us because naive T cells don't belong into an inflamed organ because they're usually primed in the lymphatic organs. But we checked that using our site-seq surface markers, and indeed, this population expressed naive-like phenotype very nicely. So just to remind you, naive T cells occur in blood and lymphatic organs and are primed to develop into the different pro and anti-inflammatory CD helper cell types. So we aimed first to check using another method, again using flow cytometry, whether this was really true. And we detected in blood and also in the liver increases in naive-like and naive CD4 positive T cells compared to a set of other liver diseases in PSC patients. So we were wondering about the transcriptomic profile of these cells. And we were surprised to detect that these naive-like T cells in the liver actually expressed a residency score that was published previously regarding effector memory T cells. So they not only had a naive phenotype, but also a tissue resident phenotype. And this is a new finding. And we confirmed that by staining liver tissue for CD45RA, a marker for naive cells. And indeed, these cells are not, or are also in the sinusoids, as you can see here, but they are also quite abundant in the portal tracts and around the bile ducts. So we next wanted to know what they do in the liver and where they develop. And for this, we performed trajectory analyses, complicated bioinformatical analyses defining some of the known endpoints for development. And indeed, we saw that these cells tend to develop into Th17 polarized T cells, almost 60% of them. And we then aim to validate that using, again, blood cells in vitro. We polarized naive peripheral blood T cells to the Th17 phenotype, and we saw that in PSC patients, this was increased compared to healthy. So to sum this up, I showed these data, and this is very selective, personal and new data, unpublished data, to demonstrate that these new technologies can be used to find new cell populations maybe involved in the pathogenesis of PSC in blood, but also in liver tissue. So let's change gears and come to the clinical part of my presentation. The next challenge, I think, we have not met in sufficient detail is the diagnosis of PSC and its complications, and mainly the early diagnosis of the disease and its complications. We use magnetic resonance imaging, that is clear, for many years now to diagnose the disease, and you in Paris have performed beautiful studies regarding its value in predicting disease course. And I'm not going to reference those because I think you all know them. But I want to highlight that I think that the interaction between hepatologists and radiologists, what we try to support in the MRI working group of the International PSC Study Group, is of paramount importance, not only to interpret these pictures, but also to guarantee an optimal quality of MRI performed. And we have, for this reason, published a position statement clearly highlighting the technical aspects of this examination. And I think it's very worthwhile discussing with the local radiologists. So the early diagnosis is an unresolved issue. And I want to highlight this work published from Oslo, where they evaluated an at-risk population, that is, patients with inflammatory bowel disease without prior PSC, in a standardized fashion using MRCP. And they were able to increase the diagnostic yield almost fourfold compared to the 2% with a previously known PSC to over 8% of patients with a likely PSC diagnosis. So I think focusing on the at-risk populations is one way to diagnose subclinical PSC. And why is this so important? I think what we see in our clinics, and Michael Manns has once called this the cirrhosis of the bile ducts. This is late stage disease, and it's probably much too late for any intervention focusing on the immunology of the disease. So what we have to detect if we want to be successful in preventing disease progression, is disease in the preclinical and early clinical stage. And we are far from doing that. But that's not the worst thing. The worst thing is that even in advanced stage disease, we are not able to really interpret our MRI findings in a consistent way. So some time ago, we performed this study where we presented case vignettes, a short clinical summary, a 3D video of an MRCP, and coronal sections as a video. And it was really frightening how great the discordance was among Psc experts in interpreting these pictures. So one of the, you would say, easiest and probably most important things in an MRCP is to detect patients with a dominant stricture. But there was no consensus whatsoever whether you could call this dominant strictures or not. And this is very important because about 50% of these patients will develop dominant strictures or high-grade strictures during their lifetime. And we are always afraid that this could be a malignant stricture and giving the difficulties in differentiating malignant from benign strictures. I think MRI still has much to improve there. So the greatest risk for our patients is the enormous risk to develop hepatobiliary malignancy, mainly hilar cholangiocarcinoma, but also at other sites in the biliary system, also in the gallbladder, and in those patients with coexisting inflammatory bowel disease, the increased risk of colorectal carcinoma. So the risk to develop cholangiocarcinoma increases over time in an almost linear fashion. Keep in mind the risk of gallbladder cancer and the risk of gallbladder polyps to develop into cancer. And I think it is important to remember that the highest risk, and it is given between 30 and even 60% of all cases, present within the first year of diagnosing PSC. Thereafter, the annual incidence is around 0.5 to 1%. And this risk clearly relates to the age of the patients. So we see very few young patients, but we see them who develop cholangiocarcinoma. But with increasing age, and if you look at this curve of the over 60-year-old patient, after 20 years, 40% risk of hepatobiliary malignancy. So this is really enormous. And we have to find better ways to risk stratify these patients for surveillance. The diagnosis of the carcinoma in the stricture can be very challenging. This is a picture of a young lady, 28 years old, with a high-grade stricture. We could not detect malignancy using standard technology, but then under a cholangioscopic view, this is possible. So I think we should use all the technology we have in the center to try to diagnose these tumors. It's a challenge. On the left-hand side, a high-grade hilar stricture to the left side of the liver. We could not pass it using regular endoscopy. So we used a percutaneous approach, a rendezvous approach, and then internalized. And this was a benign stricture, which we observed for many years before liver transplantation was necessary. So on the right-hand side, you see a malignant stricture. This is clear in the extrahepatic bile duct, but there are many patients where this is far from clear. And keep in mind, almost or more than half of the patients will develop these high-grade strictures, clearly a sign of risk. So I want to show the stepwise approach by the Swedish group of Annika Bergqvist, which just demonstrates that you should use all the technology you have at hand to diagnose these malignancies. So the sensitivity increases with the number of technologies you use, and in the end, including cholangioscopy and direct sampling of the stricture yields the best results. We perform regular ultrasound examinations next to MRI because ultrasound has a much better spatial resolution and it can show you the very small polyps. And this one is a PSC patient, a young man who developed within a few months, only 5 months, a gallbladder carcinoma that could not be resected anymore. It was already metastasized into the liver, and he died shortly thereafter. So we discuss cholecystectomy in any patient with a confirmed polyp if a risk of the liver disease allows that. So this is just the schematic overview of our surveillance of patients, and I think most centers do it in a quite similar way. We perform MRI on a yearly basis, ultrasound every 6 months. If there's a new stricture, you proceed. If there's a gallbladder polyp, you discuss cholecystectomy. In those with a new stricture, you complement the cross-sectional imaging. If you did not use contrast in your initial MRI, you should then add a contrast-based MRI. And the most important is getting samples from the stricture. And then clearly, if you have CCA, either resection or more combined treatment. And if you don't diagnose it and still have the suspicion, you have to go back in a very short period of time to repeat all that in order to look for the disease. So with colorectal cancer, it's a bit easier. But keep in mind that patients with PSC and colitis are the high-risk group to develop colorectal cancer. This has been confirmed recently from the UK. These are the population-based data from the Netherlands, clearly showing that patients with PSC IBD have an increased risk compared to patients with IBD alone. They also have an increased risk, but it's much smaller compared to PSC patients. And this was the first study to demonstrate that adherence to a surveillance protocol reduces cancer-related mortality. And this has long been unproven, unfortunately, for the presence or the development of cholangiocarcinoma. But 2 years ago, there was a first hint from a retrospective study from the Mayo Clinic, which can be criticized because it's a highly selective approach. But the risk to die and to develop a recurrence of cancer was much smaller in the surveillance group compared to the no surveillance group. And survival was also significantly better. And there's now a very nice study in Press in Gastroenterology from Palak Trivedi from Birmingham, who in a very large population-based cohort of IBD patients, almost 300,000 patients, investigated a subgroup of PSC patients and whether they adhere to an annual surveillance strategy or not. And this study confirms that the mortality from hepatobiliary cancer is reduced if patients adhere to surveillance. This was not significant anymore when you focus just on the cholangiocarcinoma patients, but it's another hint to the fact that patients may benefit from surveillance. And some of you know that there's another retrospective study by Annika Bergqvist also examining the value of surveillance regarding patient survival, and it also confirms a better survival of patients adhering to surveillance. So I think where we should go in the future is to offer a more risk-adapted surveillance strategy, including the things we already know, the risk factors such as age, the risk factor type of disease. So small duct and AIH-associated PSC have much less risk, but also the type of inflammatory bowel disease present. And then there's a set of new markers developing, namely antibodies, for example, against GP2, which demonstrate a significantly increased risk to develop cholangiocarcinoma, and recently also PR3 anti-neutrophil cytoplasmic antibodies confirmed in the study by Eva Wunsch from Poland. So coming to the last large challenge in PSC, obviously that is treatment. You know that to date there is no study confirming a positive effect of medication on the course of PSC. This is just one example of the studies demonstrating that a drop in alkaline phosphatase is associated with an improved survival. However, this was independent from the use of urso, and I think we are still lacking and will be lacking for quite some time an effective drug treatment. And this comes back then to the initial challenge of understanding disease pathogenesis. Especially in the young patients and the children, we have considerable overlap with autoimmune hepatitis, by some called autoimmune sclerosing cholangitis. These patients may benefit from immunosuppressive treatment. I think we have to look for the inflammatory activity the more the younger the patient is, and perform liver biopsy in those patients to really determine the degree of inflammation. And from my experience, determining inflammatory activity in a PSC patients just based on liver enzymes is very difficult. You sometimes have transaminases of several hundred, and if you perform biopsy, you will see a hepatitis activity of almost absent. So I think we have to perform a biopsy in those patients. And there's a set of new drugs under development and in clinical trials, and one of them is the side chain modified ursodeoxycholic acid, NOR-URSO, which increases via the hepatobiliary shunting the expression of bicarbonate into the biliary lumen, and thus may protect the bile ducts. So we know from the phase 2 study that NOR-URSO decreases alkaline phosphatase levels, and there's an ongoing phase 3 study, but this study will only be ended in 2025, so there are still a few years to come before we know the results of this 4-year trial. There are ongoing discussions, and it is a very difficult decision, I think, in a clinical case-by-case discussion, whether the patient will benefit from dilation of strictures, depending on the multitude of strictures, on the presence of cirrhosis, etc. And the question is a regular ERCP surveillance protocol and dilation protocol of benefit for our patients? And there has been this study last year published in Gut from the Heidelberg group, where they retrospectively analyzed the entire cohort over a very long observation period. And they claim that a regular scheduled ERCP with dilatation is superior to on-demand ERCP. Looking at the survival curves, I'm not so sure about this effect, because what you can see is that within the first 3 years, the curves, they open up, but then afterwards they are quite parallel in the long-term follow-up, suggesting to me that some sort of selection bias was happening in the beginning of this study. And I think it's you can nicely debate on the relevance of this study, but it did not change our practice, at least in Hamburg. What we know is that you can safely perform ERCP and dilation treatment also in PSC patients with established cirrhosis. In this study, we collected all the ERCPs we performed in our center with patients with a confirmed, histologically confirmed or elastography-based confirmed presence of cirrhosis. And the risk actually was similar in both groups. However, the effectiveness was much reduced in patients with cirrhosis, and we did not achieve a lasting reduction of alkaline phosphatase levels after the second dilation treatment, whereas this was the case in patients without cirrhosis. I think the indication for dilation treatment should be quite restrictive in patients with PSC-associated cirrhosis because it just does not change much concerning the disease course. So, dear friends, ladies and gentlemen, let me conclude from this overview of the still existing many challenges in PSC. We definitely need to understand better disease pathogenesis to develop targeted treatment of this disease. The diagnosis of early PSC still is a huge challenge, and we just are too late. We don't have an effective medical treatment, and I think we don't have an effective endoscopic treatment besides those patients with a single really functionally relevant strictures whom we can clearly help also on the long term. That is why we have to try to include our patients in clinical studies whenever possible, and there are more to come. One of the problems of the clinical studies is the definition of a good biomarker serving as a surrogate endpoint of the studies. That is why, for example, the NORSO study uses liver biopsy as endpoints, which is difficult for our patients to accept. I think one of the most important things we have to keep in mind regarding the care of patients with PSC is the recommended surveillance. We do it as an ultrasound every 6 months and an MRI every 12 months, but clearly there's no good evidence to support that still today. Let me end by mentioning the European Reference Network for Rare Liver Diseases, which is coordinated by Ansgar Lohse in Hamburg. This network can be used, similar to your network, to present difficult patients on a Europe-wide level. And if you have adult patients you want to present here in a multidisciplinary or multi-expert online forum, you can contact this email address for adult patients. And for children, this is coordinated by Toni Ilhardt in Tübingen, also in Germany. And I want to end with thanking the funding agencies that support our work, thanking the fantastic clinical team, but also the lab members. And I want to highlight here Tobias Poch, who was performing the single cell studies in his PhD work, and Timo Lewinsky, currently at the Weizmann, who is head of our microbiome analyses. And with this, I thank you for your for listening, and I'm happy to answer any questions that come up. Thank you, Christophe.
Christophe, congrats for this very clear, complete and informative presentation about PSC. I have already a couple of questions from the audience. First, regarding pathogenesis, a question from Dr. Monique Fabre. Have you studied the profile of PSC by fluid and showed also a specific microbiota profile? And have you some data in the literature concerning pediatrics PSC?
So we've studied the biofluid in adult patients in our controlled study. It's a challenging study because obviously you don't get healthy controls because it's unethical to perform ERCP in healthies. We've tried to use gallbladder bile from living liver donors for liver transplantation, but they all receive peri-interventional antibiotics and they eradicate within a few hours the susceptible bacterial species. I'm not aware of any pediatric data regarding biliary microbiota, and there's, to my knowledge, only 2 studies on it in adults. One is from Finland, which did not show significant associations, and one is our controlled study.
I understand from your very fascinating presentation that at the origin, for you, PSC is not a disease of bile, but a gut and portal blood disease. Is it correct?
No, I don't think it's what I wanted to transport. I think it's the interaction, and I think that the biliary lumen plays an important role. I'm quite convinced actually that the interaction of bacteria and probably also fungi And the biliary barrier is a very important part of disease pathogenesis. However, having said that, I think it's really a challenge to study that in humans. But we're trying to get there, and we're currently performing a study using biliary brushings where we aim to analyze also the mucosa adherent microbiome in these patients. But I think, yeah, it's probably, so my thinking of this is that probably the threshold is set by the gut-liver interaction. So it's probably increased or lowered by the gut-liver interaction in PSC, and then the insult, the action insult to the bile ducts comes from the biliary lumen.
Okay.
But that's
another question from Professor Chantal, who said, to continue questions about pathogenesis. How do you envision resident naive CD4 T cells in the course of PSC? Are they present from the beginning? Do they accumulate in response to what? Question?
Chantal, I think that's an excellent question. We don't know because our access to early stage PSC tissue and the difficulties technique-wise prevented us so far from analyzing early stage PSC liver tissue. But clearly it's an unresolved topic, and this issue of tissue resident naive cells, it's not absolutely new in other organs, but it's new in the liver, and it's open for speculation what they do there, how they get there, and whether they persist. I think there's a lot to look at there.
Okay. Coming back to clinics, how do you make a difference between PSC and autoimmune sclerosing cholangitis in children? And so how does it influence your treatment?
Yeah, so as I mentioned, I think in children, if there's any hint to increased inflammatory activity, they should receive a liver biopsy. And if they have an increased hepatitis activity, they should receive immunosuppressive treatment. It's not so clear whether that really has a huge impact on disease progression, because in the end, the PSC component will probably determine the outcome of the disease. But that's the recommendation. And on the other hand, that also means that in young patients with autoimmune hepatitis, I think we should look for bile duct changes using MRCP. And that's something that I think we still in the overall community quite frequently don't do.
Another question from Olivier Chazouillère. Are you hearing me, Christophe?
I'm hearing you, but someone muted me, so I'm unmuted again.
Well, do you recommend MRCP in every IBD patient, regardless of symptoms or biology?
Yeah, that's another difficult question. I mean, if you take the data from Norway seriously, there's a point in doing that. Yeah, but it's not a guideline recommendation or anything that is based on a validation study. So I think we should validate these data. And if it's validated, then yeah, we should screen our colitis, at least our colitis patients.
And in your own practice, what is the real place of endoscopy, both for screening and detecting cholangiocarcinoma and for treatment of stenosis? What is the proportion of patients who can benefit from this procedure? In our own experience, it is very anecdotal, and we are some results which are not very convincing. So what is your opinion?
Yeah, so I think endoscopy has a clear role in diagnosing these high-grade strictures to look for malignancy. And if you have a single or very few strictures within around 2 to 3 centimeters of the hilum, I think it's worthwhile trying to dilate them in patients that have elevated liver enzymes or rising enzymes or symptoms or recurrent cholangitis. Having said that, I also care for many patients who have disastrous bile ducts, whom we did not perform ERCP anymore, and they're absolutely stable for many years. So I think clearly this is another unresolved issue, and I think it has to be decided upon a case-by-case discussion. I think we have many patients clearly benefiting from that dilation, but we also have patients whom we make worse by introducing bacteria and other complications. And it always is a difficult decision.
Yeah, yeah. Another question.
I'm not a fan of regular ERCP dilation protocols like they do it in Helsinki or maybe also in Heidelberg. I don't think that's justified, and we have to keep in mind that the radiation exposure in these young patients, if you do a yearly ERC, is quite considerable.
Okay. A question from a pediatrician, Dr. Frédéric Gautran. Would you recommend oral vancomycin or low dose of UDC as first-line treatment? As a second question, as a pediatrician, we hopefully don't see cholangiocarcinoma in pediatric PSC. At what age do you recommend starting systematic screening?
Yeah, so I think there are very few reported patients, children with cholangiocarcinoma. I don't feel it's justified actually before the age of 18. But when they transition to adult care, I think we should start doing that. And we see patients in the 20s having cholangiocarcinoma. And the question regarding Vanco and Urso, so we are great Urso users, but it's more despair than based on any data. However, I do believe that especially in the early stages, Urso could be of benefit. And it doesn't do any harm, I think, if you don't dose it in a too high dose. So we give it, and I would also give it to kids. And regarding Vanco, it's a difficult question because, I mean, this new study clearly showed that it doesn't do a difference, but there are single patients that may benefit from it. So in children, it might be justified to have a short course Vanco treatment trial. And if the patient beautifully responds, everything's fine. If not, it should be stopped after a few weeks, I think.
Okay. So thank you very much, Christophe. We have finished our questions. Thank you for your very nice overview of this very hard to treat disease.